Hi, everybody. It's Lisa Salberg here at the Hypertrophic Cardiomyopathy Association with a featured presentation today. We have Dr. David Fermin of Spectrum Health in Grand Rapids, Michigan, with us to discuss both their Hypertrophic Cardiomyopathy Association Recognized Center of Excellence and the topic of advanced heart failure and hypertrophic cardiomyopathy. So for today's talk, we're going to have an opportunity for question and answer at the end of the segment. And I do encourage you to ask questions or share your experience with the Center of Excellence that we're discussing today, which is Spectrum in Grand Rapids. But we cannot get into very individualized questions about your individual hypertrophic. But if you have general questions about HCM or things you'd like to have clarified in a general sense, we'll be more than happy to address those issues. So without further ado, I am going to have Dr. David Fermin join me here on the screen. Welcome, David, to the program.
Hi, Lisa. Thanks for having me.
Of course. We tried to do this a while ago, but we had some technical difficulties while we were learning the software. So thanks for sticking with us and coming back to join us again. So to start off with, we launched the Spectrum program about a year ago, and we didn't have this platform. So I wanted to give you an opportunity to tell us a little bit about the history and the unique history of your program, how it started, and why we both agree that it was a really smart thing to do.
Oh, very good. Yeah, so it really goes back several years, even though we were just recognized as a COE last year. I came here about 4 years ago after I finished my training at Mayo. But Rick McNamara, one of the senior cardiologists here, had a long-standing interest in HCM. And so what he did very smartly several years ago was started to review all of the patients in our practice that had a diagnosis of HCM, and to kind of look backward and see where is our practice and where are our patients before we decide where we could go from there, and then reviewed all of their echoes and everything to make sure the diagnosis was accurate. Took out some people where the diagnosis wasn't accurate, and then looked to see how these patients were being cared for. And he didn't like what he saw as far as getting guideline-based care and having them concentrated amongst a few people who were really focused on taking care of hypertrophic cardiomyopathy. So when I came, I was able to dedicate some time to it, and we were really able to get momentum to start our clinic and get some other great team members involved. And we've been really quite busy in building our program, and really happy with where we are. And I can talk a little bit more about our team members in a little bit.
Absolutely. Let's go back for a second to what Dr. McNamara actually did. I was really intrigued with the honesty of the program, to be honest with you, that he went back and said, have we gotten these things wrong in the past? I was struck with the number of people that he both cleared of diagnosis and the number that he realized that their care was probably not optimized, and then bringing them back in. Do you remember what the breakdown was in the numbers as to how many were actually cleared of diagnosis and how many went back and got retooled?
Right. So I believe there were initially close to 400 patients that had a diagnosis, or diagnosis that would be interpreted as hypertrophic cardiomyopathy, and in the end, after really carefully reviewing, ended up with just under 200 patients where we could be really confident of the diagnosis.
I think that's really, really important that we got in there better and we really understood the disease more, and LVH that was related to other etiologies were appropriately managed in that regard. So bravo for being brave enough to do that. That took some courage from the part of the medical center to be able to go do that. And it took a lot of time too. That took you over a year.
Mm-hmm.
Yeah. So that was a big commitment. And on behalf of the patients that you both cleared the diagnosis formally, I thank you for that very innovative move. So let's talk about your team. So how many members of the team do we have, and what disciplines are covered?
Okay, well, we really have, we feel like a dream team because we just love working with each other. And we come from a variety of disciplines and really respect each other's opinions. And we just love taking care of our patients. So we have three main cardiologists who see patients in the HCM clinic. Myself, Dr. Rick McNamara, who I've already spoken about, and Dr. Jeff Decker. We have two nurses who are dedicated to the HCM program. Outstanding, really experienced cardiovascular nurses, Amy Pruce and Sue Philpott. We have an excellent physician assistant who works in the clinic with us, Lori Singer, who has many years of heart failure and EP experience in Cleveland. And you know, we have EP. We're fortunate to have kind of a collection or like a diaspora from various centers of excellence. We have Dr. Al Albano, who trained at Tufts, Najib Chalfoun from Penn. On the pediatric side, we just added Dr. Stanley Sidor from Yale. And we have some dedicated cardiac MRI imagers, Dr. Wasam Abdullah, Laura Franey. There's so many people that we could that we could talk about who spend a lot of time with our HCM program. Ryan Rottermer, our geneticist who works with us in the clinic. We have social worker Maureen Norp. So just a really comprehensive group of folks.
And I think you brought almost all of them to the summit.
Yeah, as many as we could possibly spare.
You had a very big contingency at the summit. It was great. And you do all appear to really enjoy spending time together and working together. I witnessed it myself when I came for the site visit and then again at the summit. So it's pretty amazing. You also have created a support group, and I was happy to come out and help you launch that. So you've got all of these wonderful elements for the program, and I really commend you on the innovative manner in which you helped develop the program and that it's running, because we're hearing wonderful feedback from those in your care. So now we understand the setting that these patients are being treated in, but I really wanted to kind of talk to you about advanced heart failure in HCM, because we are doing such a great job getting people, getting them the treatment they need for sudden death assessment and ICD implantation. And we're keeping people alive and healthy a lot longer than we maybe did in the past. But the consequence of that is some people are moving into a more advanced stage of heart failure. What does that exactly mean, advanced heart failure, and how do we treat it?
Yeah, and that was a topic of attention at the summit. So it's clearly well recognized that there's probably an increasing incidence of advanced heart failure in HCM. Just like with other heart conditions that we're doing a better job treating, now patients are living long enough and they're going into heart failure. It does mean some different things to patients with HCM. I mean, different things than what those patients might be accustomed to in terms of their HCM treatment, their risks and so forth and their prognosis. But also, as I talked about when I did our little heart failure webinar a couple of months ago, their heart failure may be very different in some ways than heart failure specialists might be typically accustomed to treating. And more importantly, they might have to transition from their HCM center or add a heart failure specialist.
And at Spectrum, you have one and the same at your program and in your model. They can stay with the same team.
We can stay with the same team. Yeah, we just kind of add some elements to the team, but I'm, happy that I can sort of bridge that gap, being also in the heart failure and transplant program.
So while we're talking about heart failure, a question came up in our private group the other day, and it is a challenging question that does pop from time to time, and that is, what does it mean to have a high troponin level in hypertrophic cardiomyopathy when you don't have coronary artery disease and it's been proven, and you're young?
So troponin level is can be a somewhat non-specific marker of myocardial or stress or injury to the heart cells. It doesn't necessarily obviously mean that there's a blockage somewhere or a myocardial infarction or a heart attack going on. It's elevated in the majority of patients who have acute heart failure for any reason. So I would say, if there's a young patient who you've thoroughly evaluated, they don't have coronary disease, they come in with an elevated troponin. Most important things are, what else is going on along with the elevated troponin, what the degree of elevation is, and doing serial troponins to trend it to see if there's a significant increase. And if there's not, then it's probably just related to the acute heart failure symptoms. But the only other things that we talked about earlier is if you have a patient that has other cardiac risk factors,
Right.
Clearly, if you have HCM, you can still obviously develop coronary disease, and that needs to be considered too.
Right, completely. So if somebody's young and they have a blood test and they come back and say your troponin levels mildly elevated or elevated, this is something that should be managed over time. It's not necessarily as acute of a situation as somebody who's 65, has not had a cardiac cath, and we don't know if there's coronary artery disease or not. And is it reasonable to suspect that in a young patient with HCM and a higher troponin level, that this could just be part of the disease process where there might have actually been a little fibrosis development or scar development or something going on a very, very subtle basis that might have caused that?
Correct. Yeah, in patients with HCM or with other types of chronic heart failure, there might be low-level chronic elevations in their troponin along with their NT-proBNP, one of the other biomarkers of heart failure. They might have a chronic low-level elevation of that, and that's why it's important to take into account the degree of elevation, what it is compared to what they might have measured in the past, and to do a couple of measurements to see if it's actually increasing or just stable.
Fantastic. Thank you for sharing that. It was just a timely topic, and I figured I'd pick your mind while we had you here. So what do you see, getting back to the bigger picture of HCM, what are the challenges to the care model of hypertrophic cardiomyopathy?
So I think the biggest challenge is really getting all the resources together. In our experience, getting all these resources together, literally physically in the same place, getting us to meet together and to work together to review and take care of these patients. Because it takes time. It takes more time than you'd usually spend with patients. We're just really fortunate that our institution was really supportive of that. Because you're not going to see as many patients necessarily in a day, and it might initially look like it's not as financially feasible, but that hasn't really been an issue for us, and we're really dedicated as an institution to supporting the care of these patients. The other things are really in finding the patients. Dr. McNamara went back and with the team that was here before I was, found the patients that we needed to kind of centralize and not just have every cardiologist taking care of 2 or 3 HCM patients, right, so they can get the best care. But the other thing, something that you talked a lot about, Lisa, the harder thing is to find the patients, to find the other patients. There's 1 in 300 patients or 1 in 200 out there. Where are they? Are they walking around with a different diagnosis, with a wrong diagnosis, or just no diagnosis? And where, how do we find those patients?
And that's where we need to start working with your community to change your well child examinations to include cardiac features, so that we can help identify not only the child who might be at risk, but the family that might be at risk. So we'll have to start digging into that in 2018 and see if we can make some headway with your legislative initiatives in your state to maybe make that happen, because we just paused. I do believe that sustainable measures are what are really going to make the difference long term. We can pop up and we can try to do a screening here or there, but that doesn't make sustainable change.
I agree.
Sustainable change. We need to educate the medical community better. There have been a couple of comments lately in our closed group of GPs and physicians. This one's going to make your hair curl a little bit. Sorry. GP just told one of our members that he brought in some students while he was visiting with her and said, "You might have students here." She's like, "Great, bring them in." And then he proceeded to tell his students, that hypertrophic cardiomyopathy was caused by obesity or an idiopathic nature.
Mm-hmm.
And she tried to correct him and say, no, it's a genetic disorder. He shut her down and basically told her she had HCM because she was fat.
Oh, okay.
This is what we're up against.
Yeah.
We have a very long journey up that mountain to get to that awareness level. So we are definitely going to have to come up with models within each catchment area from our centers of excellence to get out to the GP level and dispel all the myths associated with hypertrophic cardiomyopathy. So get on your boots. We're going to go out there and get into the trenches and figure this out. So I'm very conversational today. I normally just ask questions.
No, that's good. That's good.
So let's talk about HCM research. Where do you think we're going? What interests do you guys have? What's going on?
Yeah, we saw a lot of really exciting things that inspired us at the HCM Summit. What's going on worldwide in terms of basic research, clinical research with HCM. We had also at the same time that we delineated what our patient population was, started designing a registry so that we would be able to put all of our patient data into a registry. It took quite a while to get that right and to get the design of it right. But we now have a registry that could be compatible with collaborating with other institutions, but we have it locally. We have over 400 patients consented for the registry and are really excited, because this is our patient population. It kind of feels like we have a unique, every center has its own unique patient population. And I feel like ours has its own unique features and, maybe a unique story to tell once we get into the data of, what's the genetic distribution, how do our patients present? And they can really, it's the patients that tell the story of HCM, not the doctors, because you live it. And so that's exciting. It takes a long time. It's a lot of work, but we think that it will really have benefits, especially if we can eventually sort of connect with other registries. We'd really love to be able to be involved in clinical trials, like the upcoming Explorer trial. We're working to hopefully be a part of that because then it allows our patients to have access to new therapies and opportunities to participate in that. And so those are the immediate things. And then, there are the future directions like, disruptive technologies like monitoring and things, to maybe identify patients that at HCM, with HCM that, to get better risk stratification.
So talking about that for a second, I came back from Silicon Valley and there's a lot of cool stuff going on out there. And there's all this talk about wearable technology and what we can learn from it. And I just see a great big opportunity to really identify trends and, what is the good day, bad day thing? Can we predict it if we're monitoring continuously heart rate, exercise, fluid consumption, food consumption? Is there a way that we can maybe figure out what these true triggers to the bad days are and work to mediate them? And maybe wearable technology will get us there? What do you think?
I definitely think so. There's a lot of opportunities there. That presentation by Dr. Ashley from Stanford at the summit was really interesting, and I think there's a lot that could be done. And then you've got in terms of tracking activity and what is safe and healthy, and encouraging healthy lifestyles for patients with HCM, being comfortable with that. The Live HCM study, which you'll be talking about, I think tomorrow.
This afternoon at 4:30.
Oh, this afternoon already. Yeah, good.
Today.
So yeah, so many exciting things to hopefully improve the quality of life and be able to tell people with HCM a little bit more about what is your risk condition and those sort of things.
Well, yes, I'll take the little plug right now while I've got the people who are watching this one. If you're not participating in Live HCM and you're between the ages of 8 and 60, please look up livehcm.org and you can enroll and learn about the study. Or you can watch this afternoon when the two co-PIs and I have a conversation. So I'll have Rachel Lampert from Yale and Charlene Day from the University of Michigan joining us to discuss Live HCM at 4:30 Eastern today. So we talked a little bit about research. I I think wearable technology is going to be cool. Cross our fingers. But what are your hopes for the future of hypertrophic cardiomyopathy care?
So yeah, kind of connected to what we were just talking about. I think better sort of monitoring and risk stratification. Because I think we definitely have. We have risk models and everything, but I can't. It's hard to imagine, like, when you're talking to people, trying to counsel them about their prognosis, their risk of sudden cardiac death. You have a good prognosis, but there's a certain risk of sudden cardiac death. I mean, I can't imagine if I had the diagnosis. That's kind of a dichotomy that would be hard for me to reconcile. I don't know. I think there's a lot more exciting work that could be done in terms of risk stratification, and then in specific therapies. We don't really have specific drug therapies for HCM. There have been some promising ones that have kind of gone by the wayside, but what we were just talking about, the mavacamten could be promising. And then about more advanced therapies, gene editing therapies. I think that's down the road. And HCM is a very complex disease and such variable genetics and variable presentation within families and from family to family that I think it's really hard to say where that is going to go exactly, but we'll watch that with interest.
I think there's some really interesting stuff coming up. Mm-hmm. We are talking to our partners at Myocardia about assisting in the recruitment aspect of the upcoming trial. We have some goals here that if we can come up with that we will be able to speed the opportunity to get people enrolled in the trial, which is often the longest, most cumbersome aspect of doing a clinical trial. And the faster we get the patients involved, the faster we get answers. Even if they're not great answers, we learn something and then we can retool and move forward. But I think, based on what I'm learning, this has some real possible functionality and may actually improve quality of life for patients, but we need to do the trial to learn. I call it a little unbridled enthusiasm right now, stealing that term from somebody you used to work with, Rick Nishimura. But I think we can start to be a little optimistic that there might be another tool in the tool bag soon, and that we'll have something to work with. So we'll see. We will definitely see. Yeah. So I wanted to pitch a little fundraising event that's going to be going on in your region. And I know that your staff is going to be helping the family out, and the event will support the Hypertrophic Cardiomyopathy Association. And it's Philip Shippert Memorial 5K, and it's going to take place on March 24th. And this is going to be in Grand Rapids at a winery. I'm not sure if I'd want to run at a winery or I'd be sitting down having a glass of wine during the 5K.
You could do both.
You could do both. You could run the 5K and then have the glass of wine because you just burned off all the calories. But while we discuss this, is it safe for most patients with HCM, if they're in condition and they've run before, to participate in a 5K?
That is a pretty, you have to individualize it, but in general, we really try to encourage patients with HCM, especially since many are diagnosed younger, to really have an active cardiovascular lifestyle. And I think more of the evidence is coming out that it's safe to do moderate aerobic exercise activity, as long as you said, they're conditioned and you've been followed up and evaluated. It is generally safe for stable patients that get regular follow-up to do aerobic exercise activity.
I thought you'd say something like that, but we're not always going to win our age group, but we can participate. Even if it takes 45 minutes or an hour to finish a 5K, you did it and you walked, and it's a healthy activity for most people if you can tolerate it.
Yeah.
I will open the floor to questions if anybody wants to hit the send button on any questions they might have today. We are having a small group today watching us live, but we know that these programs get watched after they're live. It is 12:30 Eastern Time on February 15th right now. So if you're watching it at any other time, you're watching it after it's already happened. We will try to answer those questions as they pop up on Facebook. And if there's any questions directly to Dr. Fermin, we will forward them to him for his comments. So if you have questions, now's the time to ask. We don't have anything pending here right now. So we have quiet people today, which is an unusual event for me. We normally have chatty people who want to share their experiences and ask questions. So if you do have any questions, now would be the time to ask. So what's going to be happening in the next year at your HCM Center while we wait for questions? Anything new coming? Any new staff? What's going on?
Don't anticipate any staff changes. You know, we've been busy with referrals. We're trying to do more outreach, you know, both community education and education amongst cardiologists, primary care in our region. So that's good. We're trying to put together, you know, in conjunction with the HCMA, a CME event. We hope to do that late fall, and we're working on that now. You know, inviting a speaker. We're still working out the details, so I won't commit to anything.
We're not going to announce anything today,
but we really hope to do that to kind of generate some more interest in the community, and then after that to do more, to do another community education event, hopefully in conjunction with HCMA.
We would look forward to that.
Yeah.
You know that Grand Rapids holds a special place in this new heart of mine, so it's always fun to come back. It's like conquering HCM all over again.
And not a very good place with your old heart.
My old heart didn't like it, so she's going to come back in a box this time.
All right, I like it.
Back, but I'm putting her in her place in the box. I know it's strange to have your heart in a box, but I have to say, when I went out to Stanford and TSA stopped that bag and opened it up, got their attention. But they were okay with it. So Deb asked a question, would you qualify for the study? Deb, I couldn't say whether you'd qualify for the study off the top of my head because I don't have your records in front of me. But there will be inclusion criteria and exclusion criteria listed as soon as the study goes live. The study has not gone live yet. I will tell you about a new feature on the HCMA website. We've done a soft launch on it, so you'll get a newsletter once we've fixed it all up and made it look perfect. But we have a new partner. It's called Antidote. They've done a really cool thing with putting a filter over clinicaltrials.gov, and they will take a particular disease and they will figure out the commonality of the inclusion and exclusion criteria, and they'll ask you a number of questions, and they'll whittle down the studies that you might be able to participate in, and it brings it down to tell you which studies are in your region, meet your demographics, and that you might qualify for, and then you can look in a little further. I will say there's a little bit of a problem with the application right now, and that is there's one study out there. David, have you heard about the Lampoon study yet?
No, I haven't actually.
It's not run by anybody who has any experience on the large scale of hypertrophic cardiomyopathy. It's interventional cardiologists doing a catheter-based approach to managing outflow tract obstruction. And I'm very concerned about the trial because I think the patient selection issues are going to be a major issue. And if this fails, it's a little unclear as to how we're going to undo damage done. If it doesn't really address the obstruction properly. So I'm a little upset that NIH let them get through with this protocol without having high-level HCM centers involved in its care. So unfortunately, I can't weed those out through Antidote and say, yeah, don't do that one, because we're a little worried about it. But it will give people the opportunity to know about it and make their own decisions. So,
okay, I'll have to look into that.
There too much. So, Dr. Fermin, Marilyn Jacobs has a question. She's talked to us both. Have you saw anyone get off of metoprolol or toprol? So do people discontinue beta blocker therapy with hypertrophic cardiomyopathy?
Certainly, for various reasons. Some people have side effects, and we need to try alternative medications like calcium channel blockers. There's a fair number of people that have side effects, or it just may not be effective. If we're using it to treat obstruction, it might not be effective, and we might need to try something else. If you've had a myectomy or septal reduction therapy, you may only need a reduced dose, or you may not need a beta blocker after that. So there are various reasons. Yeah.
I was disappointed to see the Gilead study on eleclazine turned into a discontinuation of the study, because I really do feel that sodium channel blockers might have a bigger role to play within HCM management. Maybe some of these patients would be candidates for ranolazine.
They may be, and there was a recent study published on ranolazine, which it was not a positive study, but this is a heterogeneous or very variable group of patients, and I definitely think there is some role. Angina itself was not measured as an outcome in that study, and I think HCM patients may have angina because of microvascular disease. And I have seen it work in some patients, so I do use ranolazine.
Yeah, so if you're not tolerating the beta blockers, I guess the point of me bringing that up is there are alternative options. At the base of it all, I get a little worried when people want to stop all medication. Nobody wants to take a pill forever. Yeah. But your heart muscle isn't normal, even if there's no obstruction. You've got hypertrophy. You may have a degree of scar. You may have abnormal valves. So, you do have to balance quality of life with the meds and the risks of not being on anything to help that heart long term. So this is where centers of excellence come in critically important to help tease that out. So Marilyn says, thank you. Her husband, Marilyn's husband, and I have, hi, Tom. It's not Marilyn. You're just stealing your wife's Facebook. He had a myectomy. So Marilyn didn't have the myectomy, Tom. Okay. So good questions. All right. So we're going to let Dr. Fermin get back to work now. And I'm hoping that you'll all join me this afternoon at 4:30 with Dr. Day and Dr. Lampert to discuss the LIVE-HCM trial. We need another about 400 people to join in so we can finish the study and get the results published. So join us later. Dr. Fermin, thank you for joining us today. It's been delightful talking to you. Look forward to the great things coming out of Spectrum.
All right. Good to talk to you, Lisa.
As always. Bye-bye.
Everyone.
And